Good morning, everyone. So I wanted to do something a little bit different this year because Dia and I got some good feedback last year when we did like multimodality imaging towards the end of the second day. And I wanted to correlate the pre-procedural planning with CT to intra-procedural imaging to post-procedural imaging and bring a couple of multi-imaging modalities together for different cases. First off, I wanted to give some credit to Tara Rican for that beautiful picture. So these are the objectives, and this is going to be more like a rapid fire. So if somebody wants to stop me, I don't want to make it too cumbersome. So for most places, we've changed a little bit into pre-procedural planning rather than bringing patients directly to the cath lab. So the first thing is that we should get a gated study. It should be optimized to look at left-sided structures. And we need a delayed scan 30 to 60 seconds later. I tend to go 45 to 60 seconds. And the question becomes whether we go retrospective versus prospective. And that has to do a lot with the heart rate variability, pathology burden that your patient population has. And yesterday, one of the speakers was talking about LAA, and that's something I'm going to be referring back. For our lab, we have come up with the idea that sometimes it's better to get retrospective with current modulation. And I'm going to show a couple of examples why. Now, the question also becomes how much right heart opacification, and that depends if you want to plan transeptal puncture, if you want to aim, but in case you still want to aim to reduce the streaking artifact. What are some of the challenges? Well, the inability to hold your breath, the arrhythmia, some misalignment artifact. This is seen mostly on older generation scans that rather than the most current ones that like so many of the speakers mentioned yesterday. Inadequate opacification, scan noise, or CKD. So it's important that we go into the left atrial appendage with a notion of how different morphologies take place. And this was a seminal paper by Dr. DiBiase, who was an electrophysiologist that started ablating inside the left atrial appendage. And he realized that arrhythmia recidivism plummeted when he did that. And it was sort of dependent or contingent upon the morphology of the left atrial appendage. But again, these are some of the different morphologies I have seen while doing these procedures. And this is something that I have now grown into the habit of doing with every single case. In my Tara Rican station, I do a 3D volume render pseudocolor masking to get a better idea, which I share then with my interventional and structural colleagues. And we have a notion of what we're going to be seeing intraprocedurally. The first question is, for those of us that do TEEs, we have to see a different spectrum of normal flow versus abnormal flow. And I always tell the fellows when we're doing a TEE, this is very easy and mechanical to understand. They're going to be bimodal flows in the appendage with some sort of reverberation. When this has been looked into different studies, the disagreement does not come from the two extremes, whether normal or abnormal, but that spectrum right in the middle, which is the most challenging. And when we're doing the procedures, we have a lot of techniques that we can use. Like, for example, we can do 3D NPRs. This is other 3D NPRs with different coloring features. We can look at the velocities, and we can even do 3D Optison enhanced TE. You can see it here, and this is a whale tail appendage, and you can see the two that very easily are missed if you do only one. And lastly, this is one of my favorites, a mode color, in which you're proving that there's flow all the way to the tip of the appendage and all the way back. And you can see that there's plenty of flow and no areas of stagnation. But we can go even a step further, and like this is one of the CTs I mentioned, and this is the reconstruction, and you can place cine motions and see how this appendage is almost obliterating throughout the cardiac cycle as it fills and completely empties. And that's very important. You don't want to go into this procedure without accounting that, because one of the risks of embolization, as we continue to understand, is how much contractility the left atrial appendage has. This is CMR, and this is 4D flow CMR, an area I'm extremely interested in as we continue to learn how much of the outflow and cardiac output depends on physiological, pathological, lack thereof of normal flow. This is a patient with a thrombus. You can see this thrombus in the left atrial appendage floating, almost aching to embolize, and you can see it here on the 4D flow CMR with abnormal flow values, and you can see the T1 area. So going back to CT, how do we know what's pseudothrombus or low flow or low emptying velocities? Well, we measure, or this is how I do it in our lab. We look, and the first thing is to understand whether the appendage is homogeneously or inhomogeneously opacified. And once we have an inhomogeneous opacification of any area of the appendage, we measure the Hounsfield units, the mean, and compare it to the left atrial appendage and the ascending aorta. And generally, we want something in the range of 0.7 or higher. And then we look at the delayed, and we can compare how much the delayed improved, and that gives us sort of an indication. This is a patient that, as you can see, there's a normal finding here in the appendage. It's not homogeneously opacified. There's a filling defect there that once you go into your delayed scan, you can see that it remains there. But it's important because when we're treating patients, disease does not happen in a vacuum. As you can see, this patient has extensive native coronary artery disease. There's an infarct in the LAD territory. The cavities are dilated. So we have to sometimes take a step back, look in the chart. This patient was on no medications. I brought him to my clinic, started him on GDMT, and now this is 3 months after GDMT and him tolerating DOAC and avoiding any falls or any mishaps. And now you can see that the thrombus has resolved. The delayed scan reveals a homogeneously opacified appendage, and the velocities have markedly improved. So